So let's go ahead and start talking about some morphogenesis related to development of septa. We'll start off with the development of the atria, and this will kind of be guided by the names of the structures. If you remember the names of the structures, you will definitely understand what initially seems to be a rather confusing sequence of events. Repetition of names out loud is kind of fundamental here to avoid mixing names in your head. This is one of the rare times where you need some very active learning to really fix it in your head. So there's two ways that we can make a septum. It can form by two masses of tissue growing towards each other, and eventually the only way for them to continue growing is for them to fuse and then grow up into one structure at midline. So it will kind of look like this. I know that diagram is very interesting looking, but that is how subsepta can form. Or you can have just a single mass of tissue, and then you can actually have the proliferation of tissue or expansion towards another tissue until they fuse. And then that is the creation of another septa. And those are the concepts behind heart morphogenesis, to split one continuous chamber into four. It's important to realize that all these events are occurring simultaneously, but we divide them separately to examine each event individually and make sure that we understand how each contributes to the overall result. So let's start with the atria. A segment of tissue begins to grow from the top of the atria. It is the first segment of tissue that grows, and it's kind of a septum. That is why it is called septum primum, first septum. It extends down towards the endocardial cushion that is sitting at the juncture of the atrium and ventricles, which is all still connected by a common atrioventricular canal. So there's an actual open communication here initially when the septum primum is beginning to grow, and it's going to continue to grow down towards the endocardial cushion. Why is this opening important? Well, this is the septum primum growing down from the top. This is the endocardial cushion of the atrioventricular canal. We basically have our first communication because we've now finally divided this one continuous atria into a right and left. So this is the foramen, which means hole. This can sometimes be referred to as ostium, which also means opening, primum. So the first septum came down towards the endocardial cushion, made a narrow communication between the right and the left, so we call this the first hole, or the foramen primum. And this continues to get narrower as this septum primum continues to grow towards the endocardial cushion. So let's make sure we have a quick understanding. Go through this one more time. One-chambered atria is split by the projection of an interatrial septum, the septum primum, towards the endocardial cushion that is sitting at the junction between the atria and the ventricles. The endocardial cushion and interatrial septum do not fuse completely yet, so we now have a small hole, the first hole, connecting the newly divided left and right atria. The septum primum will actually finish growing toward the endocardial cushion, and some growth from the endocardial cushion will actually help close this foramen primum. It's gone. Well, now there's no communication between the right and the left side. Is this a problem? Yeah, it's a problem because our pulmonary vasculature is incredibly highly resistant to flow, so we need to make an opening to continue that flow from the right to the left side because we need to bypass that pulmonary circulation. Well, how do we do that? Simultaneously, as the septum primum is growing down to obliterate the foramen primum, there is apoptosis within the superior part of the septum primum. Do you remember back to the pathology chapter? What two types of apoptosis exist, and which type are we talking about here? There's the intrinsic pathway, because it is programmed cell death that is part of a developmental process. Now, what is the second type? The extrinsic. This kind of reminds you of coagulation, intrinsic, and extrinsic pathways. The extrinsic pathway is mediated by the binding of tumor necrosis factor or Fas ligand to the Fas ligand receptor. That is why it is extrinsic. It is binding a receptor that is on the exterior of the cell, hence the extrinsic pathway, while the intrinsic pathway is initiated within the cell, and it is the intrinsic that is necessary for the continuous communication from the right side to the left side of this fetal heart. Now, what do you call this newly formed hole between the right and left, allowing communication through the septum primum? Well, the septum primum just obliterated the ostium, or foramen primum. What is after 1? 2. So this is the ostium secundum, or foramen secundum. This makes a lot of sense. Thank God these Latin Anatomists had their head straight and didn't name it after themselves. So remember, it is the second hole due to intrinsic apoptosis in the superior part of the first septum or septum primum that projected down to divide the atria. Throughout this process, pulmonary flow is minimal since the fetus isn't breathing. There's incredibly high resistance in the pulmonary vasculature. The fetus is receiving oxygenated blood into the right atrium from the mother, so we must make another ostium or foramen to continue shunting blood from the right side to the left side so the fetus can deliver it to the systemic circulation. This is a connection between the right and left atria in the embryologic heart. So why isn't it called the foramen ovale yet? Well, it's kind of good that you're wondering this. We need one more step before we can call this newly formed perforation in the septum primum, aka the foramen secundum, the foramen ovale. So again, we need one more thing to happen for this foramen secundum to be called the foramen ovale. What will happen is that a small projection of growth, a second septum called the septum secundum, which makes perfect sense considering we've only had one septum so far, which was a very important processes that we just discussed. So the septum secundum will grow down to partially cover that hole that formed in the septum primum. Again, this is how things get confusing. They all are in Latin sounding names. The septum primum had a section that degenerated, which was the foramen secundum. You cover the second hole or secundum with the septum secundum. That is a great way for me to remember things, is that the septum primum obliterated the foramen primum, and then the septum secundum tries to cover the foramen secundum, but it can't all the way, because it needs to keep that patent so that we have a foramen ovale that allows communication between the right and the left, but only in one direction. And that is why this septum secundum comes down like a curtain. Another great way to visualize this is that this is the septum secundum growing down, and then this is the communication between the right and left, which is our foramen secundum. But as this septum secundum grows down, we will now call it the foramen ovale, because it curtains down over and it covers the segment to make it look oval. Hence they decided to rename it the foramen ovale. Now we're missing a huge step here, and that is that there is a degeneration of the superior part of the septum primum. So originally the septum primum completely blocked any communication between the right and left. And that is why we had to have some intrinsic apoptosis in this superior aspect of the septum primum. Now we need the septum primum to act as a flap. And what will happen is that there will be even more degeneration of the septum primum so that it just acts like a flap to cover this communication between the right and left ventricles. So you should visualize the flap that is from the septum primum as looking like this. So this is the septum primum. And this is the septum secundum. When flow is coming from the right side, it'll push the flap open. You have communication between the right and the left. But when flow tries to go from the left to the right in this direction, it pushes this septum primum, which is now our flap over the foramen ovale. This is our foramen ovale, and it blocks reverse flow. So the foramen secundum becomes the foramen ovale as this superior aspect of the septum primum continues to degenerate, and the foramen secundum is now the foramen ovale, because the septum secundum changed the shape of it to look more oval. The remnant of the septum primum acts as a unidirectional pressure valve, covering the foramen ovale to prevent any reverse flow. Reverse flow would be from the left atrium to the right atrium. Any increased pressure in the left atrium automatically pushes this unidirectional valve shut to prevent any undesired flow from the left to the right in the fetal heart. So, what happens when the infant is born? These are some incredibly high-yield concepts and facts considering it directly applies to OBGYN and pediatrics. So after birth, this right-to-left shunt is no longer necessary because we increase the oxygenation of the fetal pulmonary vasculature, which causes a vasodilation. And when you vasodilate, you increase the radius of the vessels, which leads to a decrease in resistance. So now, the pressures on the right side of the heart, which were previously very high because they were providing blood to the systemic circulation via the right ventricle pumping into the pulmonary trunk, across the ductus, and into the aorta, now the right side of the heart has experienced a greatly decreased resistance, so now the right side of the heart will be lower pressure compared to the left ventricle. So the left ventricle will slam this flap made by the septum primum very hard against the septum secundum. Eventually, you will cause fibrosis as these two tissues are pushed against each other, and you have contraction of some of the vascular smooth muscle in this area, and you will eventually completely close this foramen ovale. So essentially, the foramen ovale closes due to increased left atrial pressure pressing the flap, covering the foramen ovale tightly against the septum secundum, forming one contiguous structure. So previously we had this communication with the septum primum acting as a flap, which is S primum, and this is septum secundum. The really high pressure in the left side of the heart pushes this valve closed, and it stays closed, and it will look like this. And eventually there will be fibrosis and closure of this foramen. What would happen if your foramen ovale didn't close properly at birth? What would happen if it remained patent? Well, you'd have a patent foramen ovale, which means there's a continued communication between the right and left atria. What kind of shunt would this cause? A right to left, because you have an abnormal communication between your right and left atrium, allowing deoxygenated blood from the right side of the heart, because it did not enter the pulmonary artery and head to the lungs, mixing with oxygenated blood returning from the pulmonary vein into the left atrium. How might the examiners toss in the concept about a patent foramen ovale? Well, they'll go for it all. Let's try a trick question. You have a 22-year-old male with factor V Leiden mutation, presents after returning from his vacation with new onset left-sided hemiparesis. After performing a complete neuro workup, you confirm he suffered a stroke. You see an embolus in his right middle cerebral artery. They will not give you that image or information about the embolus in your vignette. But clinically, that would be your next move to get a CT or an MRI. But they're not going to give you that. They expect you to know what's going to happen in the rest of this vignette. So again, 22-year-old, factor V, left-sided hemiparesis after a long flight, something happened that he had a stroke. They're not going to give you that information about the stroke. They're just going to give you the neurological symptoms. The question will probably be something like, what type of diagnostic test should be ordered for this patient? So this is kind of a stretch, but it is definitely a chance that you'll be tested like this. Because you have to combine your knowledge of a coagulopathy like factor V Leiden, which means that the factor V protein is less prone to degradation, so that you have increased risk for clots, because you have more factor V means more activation of the coag cascade. Remember, it's factor 10, factor 5, factor 2, factor 1. All the dollar bills. $10 bill, $5 bill, $2, $1 bill. In ascending order of value. So, the combination of a coagulopathy plus stasis from a long flight should make you think deep vein thromboses. So this presentation isn't typical for a DVT, is it? He's got some left-sided hemiparesis that kind of indicates there was some sort of arterial embolus. So now this is where they want you to think. What do I do for my patient that has this strange coagulopathy that I've only learned in the Step 1 book and never seen in my clinic, because it's extremely rare, that just had a transcontinental flight? What is my next step? What do I need to worry about? Well, they want you to figure out what's wrong. Why is he having neurological symptoms? And the original problem is not with the brain. That is a secondary sign that you need to figure out what is the original etiology. The fact is that he's suffering from neurological symptoms means that somehow there was an embolus that crossed over from the venous side of the circulation to the arterial side of the circulation. So the venous side is obviously the right side of the heart, and the arterial side is the left side of the heart, because it's supposed to handle oxygenated blood. Normally, the pulmonary vasculature, because it has dual blood supply, can handle catching some of these emboli. Remember, it receives blood also from the bronchial arteries. So you can have an embolus infarct the artery that is from the pulmonary artery and have no problem because you have dual blood supply. But for some reason in this patient, that didn't happen. You should automatically be thinking that some abnormal communication between the arterial and venous blood is the case. Examiners love testing this kind of concept to incorporate some embryology in a much more common clinical pathology such as a DVT. You should be thinking that this patient has an abnormal communication between his atria or ventricles such as ASD, VSD, or patent foramen ovale. So as you can see here, there is going to be this movement of embolus from the right to the left. And then it can enter the aortic arch and go to the brain via one of the common carotids. This is called a paradoxical embolus because you would not expect a DVT to cause systemic neurological signs like that because you would expect it to be trapped in the pulmonary circulation. So let's review. This is just another image for us to visualize how a patent foramen ovale can lead to a paradoxical embolus. The embolus comes in, gets stuck in this flow, pushed across to the left side of the heart, and then it enters the left atrium, goes into the left ventricle, and then out through the ventricular outflow tract into the ascending aorta. It should be a functional flap, but sometimes if you do something that causes a very high increase in the pressure on the right side of the heart, you eventually can have shunting across to the left side. So let's continue to review things because this is the only way you're going to learn them. Constant discussion. So again, the septum primum comes down, fuses with the endocardial cushion. We have degeneration of the superior aspect of the septum primum, forming the ostium secundum. The septum secundum will come down and cover the ostium secundum, forming the foramen ovale. The septum primum now serves as a unidirectional flap so that there is only flow from right to left. Alright, it's time for us to do our first flash quiz. In the embryonic heart, the trabeculated part of the right atrium derives from what? So trabeculation is in the right atrium, and the smooth part of the right atrium derives from what? Well, the trabeculated part of the right atrium comes from the what? Primitive atria, and the smooth part of the right atrium comes from a horn. What horn was that? Remember this structure we drew? The sinus venosus has a left and the right horn. So again, the smooth part of the right atrium derives from the right horn of the sinus venosus. A great way for me to remember this is that sinus venosus is the smooth venous return of its right horn into the right atrium. Again, primitive atria and the right horn of the sinus venosus. Now what about the heart morphogenesis of the ventricles? The two developing ventricles have medial muscular walls that meet and slowly come together in the middle, just like we discussed about how two masses can come and fuse in the midline and continue to grow, pushing a structure in the midline superiorly. And that's what happens here. And this makes the name of this structure rather self-explanatory. Muscle is proliferating in the midline in between these two ventricles. And that is why it is called the muscular interventricular septum. It will grow and meet at the midline, causing a septum to form that's made of pure muscle. So now there is this huge communication, because it was just one huge ventricle, now it is starting to be split. Remember, there's an endocardial cushion sitting here at the atrioventricular canal. So now we have decreased this aperture. The endocardial cushion that is directly above here will grow and meet this interventricular septum so that this original opening, which was the interventricular foramen, that was previously allowing a communication between the right and left ventricles, is now going to be completely obliterated by this endocardial cushion growing in. Now what is important to note is that the endocardial cushion forms a membrane. It is not pure muscle like the interventricular septum that was formed by the growth of the muscle from the right and the left ventricles pushing up towards midline. So as you might be able to think, the membranous part is inherently just weaker and not as structurally sound as the muscular part. And that's a great way for you to remember that most defects involve the membranous part of this interventricular septum. What's important to note here is that obviously we want to completely obliterate any sort of communication between the right and the left side. There is no communication that we need during fetal life or after birth between the right and left ventricle. So this is a pretty straightforward step. If the membranous septum does not close properly, would you consider this a defect? Yes. Would you consider it a defect in the ventricular septum? Yes. Would you want to call this a ventricular septal defect? Yes. So that is the most common reason for a VSD, is a problem with the membranous septum developing. What kind of shunt would this create? Well, at birth, you would have shunting from the high pressure left ventricle across the membranous defect, or VSD, into the low pressure right ventricle. Remember, the right ventricle is pumping into the very low resistance pulmonary circuit, and that is what's driving this flow. The low resistance of the pulmonary circuit compared to the very high resistance of the systemic circulation.